On this channel, we explore concepts in clinical reasoning in medicine in a simple and systematic way. Let's get started. Here is the differences between prerenal AKI, intrinsic renal AKI, and postrenal AKI, explaining why each feature occurs step by step. Acute kidney injury AKI is broadly classified into prerenal, intrinsic, renal, and postrenal types based on the underlying mechanism. Although all three result in a decline in glomerular filtration rate, or GFR, the location of the problem before, within, or after the kidney determines the clinical, laboratory, and imaging findings. Understanding these differences requires analyzing each aspect individually. Definition and primary problem. Prerenal AKI is caused by decreased renal perfusion without structural kidney damage. The key issue is inadequate blood flow to the kidneys. Because the kidney tissue itself is initially intact, this form is potentially reversible. Intrinsic AKI, in contrast, results from direct structural injury to the kidney, affecting components such as the tubules, acute tubular necrosis, glomeruli, glomerulonephritis, interstitium, interstitial nephritis, or vasculature. Here, the nephron itself is damaged, impairing its ability to function properly. Postrenal AKI arises from obstruction of urinary outflow, which may occur anywhere from the renal pelvis to the urethra. The primary issue is not blood flow or intrinsic damage initially, but rather back pressure that interferes with filtration. Pathophysiology. Why GFR falls. In prerenal AKI, reduced renal perfusion leads to decreased hydrostatic pressure in the glomerular capillaries, thereby lowering GFR. The kidney responds by activating compensatory mechanisms such as the renin-angiotensin-aldosterone system, or RAAS, and antidiuretic hormone, or ADH release. These mechanisms promote sodium and water retention to restore circulating volume. In intrinsic AKI, the mechanism depends on the specific injury. For example, in acute tubular necrosis, or ATN, damaged tubular epithelial cells lose their polarity and slough into the tubular lumen, causing obstruction and backleak of filtrate. This leads to reduced effective filtration and impaired reabsorption. In postrenal AKI, obstruction causes increased intratubular and Bowman's capsule pressure, which directly opposes glomerular filtration. Over time, this back pressure reduces GFR and can eventually damage the renal parenchyma if not relieved. Urine output. In prerenal AKI, oliguria is common because the kidney conserves water in response to hypoperfusion. In intrinsic AKI, urine output may be reduced, can be said oliguric, or normal, can be said non-oliguric, depending on the extent of tubular damage. For example, partial tubular injury may still allow urine production. In postrenal AKI, urine output is variable. Complete obstruction may lead to anuria, while partial obstruction may present with oliguria or even normal urine output early on. Urine, sodium, and fractional excretion of sodium, or FNA. In prerenal AKI, the kidney attempts to conserve sodium to maintain intravascular volume. As a result, urine sodium is low, smaller than 20 milliequivalent per liter, and FAANA is low, smaller than 1%. This occurs because intact tubules respond appropriately to hormonal signals, aldosterone. In intrinsic AKI, especially ATN, tubular cells are damaged and cannot reabsorb sodium effectively. Urine sodium is high, larger than 40 milliequivalent per liter, and FANA is high, greater than 2%. This reflects loss of tubular reabsorptive capacity. In postrenal AKI, these values are variable. Early in obstruction, the kidney may still conserve sodium, but prolonged obstruction leads to tubular dysfunction, increasing fractional excretion of sodium. Urine, osmolality. In prerenal AKI, urine is highly concentrated, greater than 500 milliosmoles per kilogram of water, because a DH promotes water reabsorption in intact tubules. In intrinsic AKI, the kidney loses its ability to concentrate urine due to tubular damage, resulting in relatively dilute urine, smaller than 350 milliosmoles per kilogram of water. In postrenal AKI, urine osmolality varies depending on the duration and severity of obstruction. BUN or creatinine ratio. In prerenal AKI, the ratio is elevated, greater than 20:1. This occurs because urea is passively reabsorbed along with water, while creatinine is not, leading to disproportionate retention of urea. In intrinsic AKI, the ratio is typically normal, 10 up to 15:1, because tubular damage impairs urea reabsorption. In postrenal AKI, the ratio may initially be elevated similar to prerenal due to reduced flow, but later normalizes as tubular damage develops. Urine sediment. In prerenal AKI, urine sediment is typically bland because there is no structural damage. In intrinsic AKI, sediment reflects the underlying pathology. Muddy brown casts in a TN, necrotic tubular cells, RBC casts in glomerulonephritis, and WBC casts in interstitial nephritis. These findings occur because damaged cells and inflammatory elements are shed into the urine. In postrenal AKI, sediment is variable and may include hematuria or crystals, depending on the cause of obstruction. Response to fluid therapy. Prerenal AKI improves rapidly with fluid resuscitation because restoring perfusion corrects the underlying problem. Intrinsic AKI shows little or no immediate improvement with fluids, as structural damage must heal over time. Postrenal AKI improves after relief of obstruction like catheterization, as the back pressure is eliminated. Imaging findings. In prerenal AKI, imaging is usually normal because there is no structural abnormality. In intrinsic AKI, kidneys are typically normal in size initially, although chronic damage may later cause shrinkage. In postrenal AKI, imaging often reveals hydronephrosis, which is dilation of the renal pelvis and calyces due to urine accumulation upstream of the obstruction. Reversibility and prognosis. Prerenal AKI is usually fully reversible if treated promptly, since no structural damage has occurred. Intrinsic AKI has a variable prognosis depending on the severity and duration of injury. Severe or prolonged damage may lead to chronic kidney disease. Postrenal AKI is reversible if the obstruction is relieved early. However, prolonged obstruction can lead to permanent renal damage. Treatment principles. The treatment strategy directly reflects the underlying mechanism. For prerenal AKI, we restore perfusion fluids, treat shock, improve cardiac output. For intrinsic AKI, we treat the specific cause, for example, remove nephrotoxins, immunosuppression for glomerulonephritis. While for postrenal AKI, we relieve obstruction, catheterization, stenting, surgery. To sum up this discussion, the key to understanding AKI lies in recognizing that prerenal AKI is a hemodynamic problem with intact kidneys, gives adaptive sodium retention and concentrated urine. Intrinsic AKI is a structural problem, gives impaired tubular function and abnormal urine findings. Postrenal AKI is an obstructive problem, gives back pressure and variable laboratory features. Each laboratory and clinical finding can be directly explained by how the kidney responds or fails to respond to these underlying disturbances. Thank you for following this discussion. In clinical practice, what matters is not just what we know, but how we think. See you in the next discussion.